Welcome to another excellent virtual CME talk hosted by the Maricopa County Medical Society. MCMS is the oldest medical society in Arizona and one that in the last couple of years has been revitalized. We're increasing our advocacy and lobbying efforts for physicians, offering more in-person and virtual CME activities and social activities as well, and providing greater discounts through a renewed partner program. So basically the value of membership is increasing. If you're not a member of MCMS and want to join, please reach out to us. Today's discussion is with Dr. Sheetal Chhaya, and this is held under the auspices of the MCMS Diversity Subcommittee. One goal of the Medical Society is to increase the diversity, equity, and inclusion of physicians in Arizona. We'll be speaking with a lot of partners in the Valley and throughout the state about this. But part of that obviously is education about the current conditions and what's happening in medicine. Quick note about CME. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Arizona Medical Association through a joint partnership of the Moore Foundation and Maricopa County Medical Society. Moore Foundation is accredited by ArMA to provide continuing medical education for physicians. Moore Foundation designates this activity for a maximum of 1.0 AMA PRA Category 1 credits. Physicians should only claim credit commensurate with the extent of their activity, participation in this activity. Anyone watching this live session should expect to receive an email within about 7 to 10 days with a link to a post-activity survey. And anyone watching the recording can click a link in the show notes to access a similar survey. And now for our speaker. Dr. Sheetal Chhaya is chair and attending physician and medical director of medical subspecialties in the Division of Rheumatology at Valleywise Health Center. She's also clinical assistant professor at the University of Arizona College of Medicine, Phoenix, and assistant professor at Creighton University School of Medicine, Phoenix Regional Campus. Dr. Chhaya graduated from the University of Pennsylvania and earned her medical degree from UMDNJ School of Osteopathic Medicine. She completed an internal medicine residency at UMDNJ and a fellowship in rheumatology at the Cleveland Clinic Foundation. And then after fellowship, but prior to coming to Arizona, she was on faculty at Brigham and Women's Medical Center and Harvard Medical School in Boston. Dr. Chhaya is here today to speak about racial and ethnic disparities in healthcare delivery. Dr. Chhaya, thank you so much, and the floor is yours.
Thank you. Thank you so much. And thanks to the society and everybody for welcoming me. This is exciting for me. And thank you to all of you, because I know Mondays are tough, and I think we just want to kind of get on with the week. So hopefully this will be a nice little hallmark to your evening, but I will definitely respect your time. So let's get right into it. I stumbled upon racial and ethnic disparities and the whole idea of this really inadvertently. I'm not an expert, as most of us know. When we trained in traditional medical schools, we really didn't have this as the forefront. Unless you're really new into the medical field, this was something that was pretty much not talked about. And I'm so glad that it has been. But in any case, I was able to get tapped by somebody who wanted me to talk about my experiences at Valleywise many years ago at ASU. And I guess the rest is history. I grew very interested in it and did some work in it, and have enjoyed speaking about it since. So what I'm excited to do today, I have no disclosures, by the way, nothing that would affect my views discussed here, is I want to talk and I want to have a little discussion, or at least get you all thinking, if you haven't already, thinking about some of the different things that we see every day in our practices, but really identifying the disparities in healthcare. So whether it's disparities in access to and the delivery of, or what we're seeing sort of on a patient by patient basis. We want to learn the various ways in which these disparities in healthcare manifest in clinical practice, in our clinical settings. I hope we can identify various techniques. I want to show you a little bit about what's actually out there, what system placements are out there in our own institution at Valleywise that are in place to bring more equity and hopefully solution to these obstacles that our patients are seeing. And this is just the tip of the iceberg. We're very early in this. So what better time to start than now? We'll spend a few slides on understanding cultural humility, which is kind of a new concept over the past several years, though. and its role in improvement of healthcare delivery to optimize the care that we deliver to our patients. And then finally, hopefully we can help recognize the improvement that comes in patient outcomes in terms of health and their satisfaction, if we are just recognizing these factors. I mean, that's, you know, recognition is half the battle here. So, so let's move in. For those of you who are not entirely familiar with Valleywise, though, I was happy to say that May has actually been deemed by our mayor, by Kate Gallego, actually, as Valleywise Health Systems Month. We have been gaining a lot of ground in terms of the work that we do at Valleywise and the resources and services that are provided to our community. The mission is to provide non-paying and paying patients access to medical care. Many of you may know this as Maricopa County back in the day, then Maricopa Integrated Health Systems, and today through some great funding that was allotted to us, we are now Valleywise Health Systems. But the mission has remained the same. We've played the role of the safety net for the citizens of Maricopa County. We serve people of varied races, ethnicities, diversities, and language, and also various statuses of health insurance. They have complex medical conditions, varied socioeconomic statuses, and cultural sensitivities are a big part of this. I cannot emphasize enough how important this is for our trainees too, for our residents and our medical students. And as you'll see a few slides in, we're starting very early in the education of things. I was interested in learning that Maricopa County is actually the 4th most populous county among a few others in the US. But that's a huge responsibility that we have because we're providing care for our local communities in such volume. So we need to be able to be aware of how to meet individual needs, not just globally. And just a quick graphic on what we have. I mean, Valleywise Health Systems isn't just that big monstrosity of construction that's happening on Roosevelt right now, but it's got so much more. We're a level 1 trauma center. We're the 2nd largest burn unit in the country. We've got our cancer and our children's center, not to mention multiple family health centers really around the valley that serve the community that we live in. I'm at the Comprehensive Healthcare Center, which is where we do all of our med subspecialties, and we're sort of branching out now. So lots to cover. So each and every one of us probably walk into our office, you know, into our patient's room and ask, how are you feeling today, right? It's a pretty innocuous, basic question. But one thing I've learned is that asking the question is pretty much the only simple thing there. There's probably multiple factors that contribute to that answer that patient's going to give you. And it's the case with all of us. But what we realize is that multiple factors are contributing to how they are doing at that particular time, but also how they've been doing. Multiple factors contribute to health disparity. So we have to ask the question, what are these? What are those factors that contribute? What impact do they have on not only how we deliver healthcare, but to the overall health of these individual patients, right? And then what is our responsibility, I should say, in developing a new paradigm in approaching the care that we deliver to these patients? The responsibility is on us as physicians, for sure. We have questions to answer, multiple questions to answer, actually. Let me move my face here. So the first question is, what are they? What are those disparities? What is a disparity in general? Well, it's the difference in health and healthcare between those individual groups that are closely linked with social, economic, or environmental disadvantage. Now, I always hate that. Whenever I read this, it just bothers me to think that there's disadvantage, right? Look, as much as I'd love to have the rose-colored glasses on, I think we all understand that there are varying social, economic, and environmental disadvantages, including racial and ethnic disadvantages to our individuals, or else we wouldn't be having this conversation. So we know that that's what a health disparity is. Why does it matter? Well, because it affects the group facing the disparity, whether it be an African-American individual, an individual with certain disabilities, females. I mean, we can talk about all of that. It'll affect the group facing the disparity, but also limit overall gains in the quality of healthcare for the broader population. It'll increase cost, no matter what. If we have individuals who cannot access healthcare anywhere but my ER, at this point, or our ER at Valleywise. And we know that they're not going to be able to pay a dime for what care they're getting because of the structure and the system failures, if you will, or the disparities, sticking to terminology, then we know that ultimately that's cost out of the pockets of us in the community and Valleywise as a whole, or your hospital as a whole. We also know that our population is getting more diverse. So it's projected that people of color will account for 52% of the population in 2050. That's seems far away, but it's incremental. Now, what's the current status? Well, the ACA led to increased coverage for patients, but some groups still remain at the higher risk level of being uninsured, lacking access to healthcare, leading to worse outcomes. So, example, in 2018, which I know in this vortex of the pandemic we had been living in, 2018 seems like a lifetime away, but it wasn't. And not too long ago, Hispanics were measured to be 2.5 times more likely to be uninsured than white Americans. Those with income below the poverty line are 4 times more likely to lack coverage with those income at much higher levels. So again, the problem's there. We have to define it so we can actually decide how we're going to fix it. Let's see here. There we go. So there's more to it though than that, right? There's contributing factors to access to healthcare. So what I want to do here is we've identified that there's a disparity, or what the concept of health disparity is. So what are the factors that contribute? Lack of health insurance, one. Now these are global. This could happen to anybody. It doesn't matter your ethnicity or otherwise. Lack of health insurance is found specifically more in certain racial, ethnic, and socioeconomic groups. We know this, the data is public. Happens in other minority groups. We see it in our trans population. We'll see it in our patients that are individually disabled. All of this can lead to delays in access of healthcare, whether it's because you have a pre-existing condition, or you just can't access it because of financial means. There's so many things to come into play here. Secondly, lack of financial resources. We'll talk a little bit about that when we talk about some of these examples, but subsidized insurance plans may not be as amazing as they seem, and they can oftentimes limit the amount of services available. I have a patient right now. She has a terrible skin eruption. I think I know what I'm dealing with, but I'm not certain. And my differential is a little bit bigger than I'd like it to be. I need her to see a dermatologist. Her insurance isn't going to cover it. She's not going to be able to pay for that. So we're stuck, and we have to figure out how to work around that. Now, her subsidized plan is the reason why she just can't do it. She can afford other things. She just can't afford that consult. Hidden costs for assistance and subsidy are always there. And this is something we run into quite a bit, especially when we talk about our rheumatologic medications or chemotherapy. Irregular sources of care. Data has shown that compared to whites, ethnic minorities are less likely to be able to visit the same provider on a regular basis. Now, again, that's one big, heavy statement, right? But what's contributing to that is a lot. The location of where these individuals live, the location of clinics, access to these clinics. This all leads to increased urgent care and ER visits. And I think we all know that the ER and urgent care have a purpose. But when you talk about health maintenance, that's not where we're going. It's an emergency room for a reason. But unfortunately, a lot of our patients are getting their care there. Legal obstacles contribute to this. So, if you don't have insurance, it's pretty hard to get the healthcare that you need, and that access is not going to be available to individuals who have not been a resident here for less than 5 years, or for 5 years or more. So if you're undocumented, and we see our fair share of undocumented residents, we have a limitation there. There's a disparity there. The individual who is documented may have more access to those needs than others. Structural barriers. I could go on and on about how many times I've had individuals just have to not come. They've no-showed, or they cannot come to their visit because the bus didn't show up. I didn't have a ride. My son had to go to work. It's a real thing, because not every one of our patients is getting into their car and driving to us. Inconvenient appointment times. If their shift ends at 5 and I I just don't have clinic after 6 o'clock or what have you, I'm not going to be able to see them. This is sort of a global issue. Lengthy wait room times, I could go into that in a case that we'll present to you. But if an individual has to get back to work, they don't have time to be spending their lunch hour in my office. And we see that time and time again, especially with our more complex cases. So several factors will reduce the likelihood of that individual successfully making that appointment and keeping the appointment, and they may not want to come back. Lack of providers and diagnostic facilities, especially in the areas where minority populations are concentrated. You might see more of the inner city and rural communities not really having the medical facilities that are needed to help and to assist the number of patients in those pockets. And a lot of times it has obviously to do with things like reimbursement or just cost of putting up a building and then staffing it. So lots of factors there. And then my favorite of all is the language barriers, because I cannot, so many of us have family members where English is not their first language, and they're walking into an office, and just think about the fear and the concern in that patient thinking, nobody's going to understand what I have to say. And it's just probably not been the first or the third or the 8th time this has happened to them. So inadequate interpretive services are a big barrier, especially in the state of Arizona. Something we need to be very cognizant of. Now, things that are related to the racial and ethnic healthcare disparities, some of them overlap with what we just talked about, but let's not forget that there's other things, not only the communication difficulties, differences in geography. You might have pockets of individuals from one ethnic group living in one part of Phoenix versus the other that may not be served as much. So an underserved population in terms of healthcare as well. Cultural barriers for sure. I've got some great examples there that will hopefully highlight what I'm talking about there. It bothers me to talk about provider stereotyping, but we do it. And that is definitely something that needs to be overcome, and definitely something that contributes to healthcare disparity. And then of course, lack of access to providers as well. We'll talk a little bit about that. So I'm going to just jump in really quickly to this. Many of us, and if we were sitting in a room, I would ask for a show of hands, but many of us started our training at a time when we weren't really talking about social determinants of health. We weren't talking about implicit bias and obstacles and disparities to healthcare delivery or access to healthcare. But now we're seeing it so pervasive in our environment, in our medical field, and it's incredibly important that our students are learning it from jump. So the inclusion of healthcare disparity and social determinants of health in medical school curriculum has been occurring rampantly to help create future physicians who will do something to actually achieve health equality and really put it at the forefront of kind of their vital signs, really, as they're talking to patients, being fully aware of this. Medical education has really shifted quite a bit in terms of presenting facts to learn in these individuals, make it a part of the biology and the health of this individual, rather than a condition that needs to be challenged and changed. So, just some examples that are brought up in the literature is really that we talk about race, not racism. So I just want to stay there for a second or two, because it's incredibly important for us to understand that when we talk about the impact of race, there are other talks that I give where I talk to individuals about how we do have to take race into consideration sometimes, because in fact, your race and ethnicity may predispose you to a certain type of disease. Autoimmune disease is higher in the Hispanic woman as compared to the Caucasian woman. So it is important to understand it as a fact and not sort of a condition. Racism can be talked about as a separate adjunct to that. But that's not how we're teaching it. We want to teach it as poverty, not oppression, things like homosexuality, not the homophobia that laces that. That again is very important. It's a sort of a congruent type of topic, but this is where we start. The move is towards critical consciousness. If you're not thinking about it, if you're not understanding the concept of power and privilege and inequality that's embedded in this society, we're not ever going to be able to foster that communication and that commitment. And I think as physicians, we do have a responsibility towards social justice. It's not just the public policy guys, and it's not just the lawyers, and it's not just it's really all of us. We are public servants after all. What we're doing at the level of medical education is we're actually asking our students all the way up to our attendings to look at our own values, assumptions, and experiences. This is really a part of what cultural humility is. We're asking ourselves to work within what's happening now. We challenge inequality. Medical students are asked to consider structural vulnerabilities when they address patients' complete health. So talk about what other sort of injustices, what are the limitations this individual has? You know, it could be as simple as, I got a paycheck. It's either going towards the food that I'm putting on the table for my family of 5, or it's going towards a prescription that I need for me. So really that disparity is there even at that level. We're asking students to identify societal and institutional structures that really impact these clinical outcomes. Because if we identify that, we can identify where change needs to occur. And then of course, we realize things that what we consider these cultural differences, right, are actually social inequities in and of themselves. We have to ask the question of how they impact the health of our patients. And again, I know some of this sounds like we're talking in a lot of vagaries. I also know that each and every one of you understands this. You've probably experienced this with your own patients. I want to help define this by some of the examples that I'm going to bring up in the second half of this talk. Essentially, it's just not enough to say it is what it is. This is how it's been. It's really tough. They're uninsured. That's all I can do. We've got more to do. In the interest of time, because I've covered some of this, I'm going to skip over this. This will be in the lecture, but just to be aware that in graduate medical education as well, when we talk about medical education as well as interns and residents, we have as a whole, both in the Creighton system with our Valleywise residents and onward, we've really continued this teaching from medical school onward. And it really is addressed even in orientation. And I can attest to it because I've given numerous talks to the residents about this topic. We've talked about things like shared decision-making with our individual patients. And I try very hard to implement this on the daily when I have my residents every day with me as we see patients. So we really do try to bring this up as regularly as we possibly can, really making it kind of second nature for everyone. Now, the difference between cultural humility and cultural competency. So we used to talk about cultural competency, right? When we joined an institution, we all sat with human resources in a conference room, and they would give us this sort of maybe a survey, or we'd have a discussion about it, icebreakers, what have you. Cultural competency was considered a finite understanding of a set of construct of knowledge of other cultures, right? This is this is that. Boy, as I'm saying it, I'm hearing myself mentally stereotyping, right? Because I was going to give you some examples and I'm thinking, oh, I don't want to give them the example about all Indian people fill in the blank, right? That's not exactly what this was meant to do, but unfortunately, inadvertently, that's what teaching of cultural competency actually did, sort of implying that you become competent in understanding a certain culture. Replace that with what's now very well accepted as cultural humility. So this incorporates a lifelong commitment to understanding as well as self-critiquing, because we're not perfect, and self-evaluation to minimize that patient-physician power imbalance that inevitably occurs. The goal is to develop a mutually beneficial and non-paternalistic clinical and advocacy partnership, okay, between physician and patient. We have to speak on behalf of our individuals, on behalf of the partnership, the population that we're treating. So that's really the purpose of it. And cultural humility takes the physician in as an active participant in the learning of this. Now, the National Academies of Science, Engineering, and Medicine, so we all knew it as the Institute of Medicine, defines primary care. They have a definition of what primary care is. Mad kudos to all of the primary care providers out there, because it's a hard job. There's a lot there that you have to unpack every single patient. Now we're asking you to do this. But it's incredibly important to identify that not only optimal primary care, but I think optimal medical care is, it has to include an understanding of the cultural, nutritional, and that can be physical as well as emotional, and belief systems of those patients and communities that may assist, okay, or stand in the way of healthcare delivery. So we have to figure out, and we have to pick and choose what's going to be helpful. Let's play on that. What's going to be harmful? Let's try to pull that out. Medical education needs to focus on this for sure. And we've been including this into our medical training nationwide. Now, the key here is we want to avoid the pitfall of teaching this as a finite body of information. Okay, we don't want to measure it with outcomes and specific, multiple choice testing. This has got to be engagement. You commit to this. This is something that has to sort of traverse 4 years of training. It requires putting your ego aside. It requires a little bit of humility and asks for self-reflection on our own self. So I oftentimes bring up my own examples of where I may have sort of, maybe pigeonholed a patient, not understanding why I was doing it, not doing things intentionally, but really giving them, my students and my residents, an understanding of what not to do or how to correct things in the future. We have to find a way to confront our own implicit biases, our sense of racism, classism, and phobias. And again, the last lecture that we had on this several months ago was just excellent in addressing this. So I don't need to spend too much time on that. The idea is we are forming mutually respective partnerships with our patients, with the communities from which they are coming to us, and even our colleagues, so that we can all kind of enter this patient advocacy model, which is, by the way, translating into healthcare success and compliance with what we recommend to our patients. I mean, that's really what we're looking for, right? So it works. Okay. We need to, I'm just going to step back here real quick. We need to be able to say what we don't know when we don't know it. And that's really what I think cultural humility does, is it challenges that within ourselves so we can be really open as we address medical care with our individual patients. And that's really the key here, okay? So I'm going to skip over because I really want to get into some of the ways that we're addressing our patients here. If you've noticed the way that we're teaching our residents, and hopefully each and every one of us has sort of adjusted the way that we address our patients, and really, I'm sure that many of us were already doing this, we have really transitioned into patient-focused interviewing and care. That is something we are teaching our incoming house staff, our medical students, and really even teaching each other as colleagues. Oftentimes we find that the traditional model of interviewing and patient interaction with the physician is the physician will ask 90% of the questions. We've got that mental checklist, we're going down, or we've got our EMR checklist, but we ask the majority of the questions. We sort of steer away from patient-directed questioning, right? So it's either, okay, do you have a rash, oral sores, hair loss, and ever had a fever or serositis, right? We'll ask them these questions. I kind of just want to know a yes or no, right? That was the traditional model. But if they're going to sort of tell me, well, I did have a rash, but I put something on it, it went away, but it was a med that I got from Mexico, and I hear that all the time, and it really worked, doctor. If they direct it, now I've just gotten double the amount of information that I really did need before I prescribed them something that they were probably already using, just under a different name, right? Studies have shown that certain ethnic groups want as much information about their care, that's not a shocker, but they're receiving less. We have to understand why. And maybe, just maybe, it's because we're doing all the talking. We're asking all the questions. We have to do that. That's part of our history taking, right? I'm not steering away from that. But maybe if we actually are twisting it a little bit, changing it around, changing the paradigm of how we conduct that. Patient-focused interviewing is less authoritative. It's less controlling. It tells the patient that the physician, I value not only your medical, but non-medical agenda, your perspective. What are you coming to me with? What is your answer to my initial question? How are you doing today? Right? It's non-obstructive, it's not obtrusive, or intrusive, I should say. The patient will be more willing to open up. It's just less focused on the mastery of the cultural system. My goal is not to learn your culture if that is what's implying, if that is what is sort of defining how you chose to treat your rash, or why you chose not to take the medicine I recommended to you. Because the patient will lead the way. It'll give them some understanding. It'll give them trust in me. And it'll lead the way on how much or how little their background is involved in their health. Let them tell us. That way, we're not making any assumptions and we're moving into this smoothly. Okay. And then, of course, we have to be consistent. When we're dealing with a certain community, we have to be consistent throughout. And then, of course, for those of us who work within institutions, we have to make sure that this is consistent throughout the institution as well. And this is one of the hats I wear at Valleywise as well. Okay. So much of this lecture, when we try to answer the question, much of the rest of this lecture, I should say, is asking the question, if all things are equal, okay, health diagnosis, for example, right? They're in your office, okay? They got there. Does race and ethnicity affect how the physician treats the patient in practice, along with the other issues or the other disparities of health? Well, the answer is yes, and the data supports it. Disparities in the healthcare system do contribute to the overall disparities of health status. But it also affects how we as physicians have been treating our patients over so long without even knowing it. Health status is affected by environmental, genetic, and social determinants, yes. We already talked about how residential segregation, lack of access to quality education, barriers to economic opportunity, language, all of those other social determinants that we don't even really think about when we just want to treat the patient's lupus, they play a huge role. And it's only until they say, well, I can't afford the medicine, that we're made aware that this is an issue. Now, the rest of this lecture is going to be from anecdotes, things that have happened in the clinics, things that have been brought to my attention, but they're not isolated to Valleywise. We just have this patient population where some of this is all so incredibly important to understand and inherent in our patient experience. So it is important to know, though, that upon these experiences, studies that we're citing here have gathered data, and they then quantify this issue more. And I love this quote: the medical world essentially reflects the real world. It's really true. Despite our feelings that it should be never that way, you know, healthcare for you get healthcare and you get healthcare and you get healthcare. I mean, that's the way it should be, right? Rose-colored glasses just tilted a little bit down. That's not the way it is all the time. So we need to see what we can do to fix that. So I'm going to move in a little bit to a couple of sort of case studies or patients that I've had in the office. I think we need to be aware, just as a little caveat here, those of us who are medical subspecialists in autoimmune disease, for example, or those of us who treat hypertension in individuals with stroke. So I'm going to say all of us on this understand that race and ethnicity do play a role in individualizing presence of disease, who gets it, occurrence, the actual diagnosis. Hey, this is more common in the African-American individual than the Caucasian. The burden of disease on the body. Hey, the Hispanic woman's going to get more lupus nephritis than the Caucasian individual, who might get more pericarditis. The course and severity of disease and how they respond, as well as their ultimate outcome. So we know all of that, but it doesn't change the fact that the real world hits us in the face every single time, and we need to know how to fix it. We need to know how to address it first. So I'm going to put this up here. Now, typically when I talk about this, I have sort of an open discussion about it. But so we can get through the cases, I'm just going to ask you to kind of, in your own thought process behind the screen, think about how, you know, what this means to you and how this affects you. I want you to pay a little bit of attention to how it makes you feel too, as you're reading this. Maybe for some, it'll be like, yeah, I've seen it, or, oh my gosh, wow, that happens. All is, just anything's acceptable. And then we can talk about it. If you have questions, please feel free to stop me. So we had a 55-year-old female from Mexico. She presented with diffuse widespread pain. She was referred to rheumatology for the concern of SLE. Her case was presented to me by the interviewing resident. Okay, so the resident comes out to me and says, hey, doc, yeah, I've got this 55-year-old female from Mexico. She's got pain for 3 years. Her primary care wants to know if this is lupus. I asked her, she hurts all over. She says yes to every question I ask her. Dr. Chhaya, she's got that classic I syndrome. So I kind of picked my tongue up off the floor, and I asked the resident what did he tell her? And he said, well, I told her she had chronic pain and nothing could be done for her. She didn't have lupus. So what's the problem here? Well, I can think of several. And then we have to ask ourselves, what's the issue creating a barrier to this patient getting adequate care? Because right now, this resident or attending or whoever went to see this patient already has an assumption that this individual is going to have pain based on some preconceived stereotypes or notions that they already have. Patients from Mexico, probably an over dramatizer, someone who is being very dramatic about the pain, is not able to tolerate the pain. And oh, by the way, all middle-aged Mexican women feel pain and they don't respond to anything. And oh, by the way, she doesn't have lupus, it's chronic pain. It's kind of a problem. Here's the problem. I just got done telling you that Hispanic women have the highest likelihood of developing lupus as compared to their other female counterparts of different races and ethnicities. So what did we do? We lost an opportunity here to take her seriously, and possibly could have missed the diagnosis if I walked in there and said, you know what, you got pain, I'm not going to check your labs. We wouldn't have done that, but I hope you can see that this is the important thing that we need to teach. We need to kind of globalize this a little bit, keep our eyes wide open and say, wait a minute, the stereotype, that was what was causing the barrier. Had a 75-year-old Chinese female with a history of autoimmune muscle disease. So she had polymyositis. She presented with years and years and years of muscle weakness, and she'd not been taking any of the medications we had prescribed. She felt she wasn't getting better. Now, the problem with polymyositis, as we all know, is that the longer we wait, the harder it is for the muscle disease to improve. But in any case, she wasn't taking the medications. So now we have to make a decision as to whether we should change her medication regimen, and a discussion ensues between provider and the patient. Are you even interested in changing your medications? The PCP is concerned that she's not even going to be interested. The primary care provider says, you know what, she's just using her Chinese herbs. We're fine. We're not going to move forward with this. I'm not going to even tell her we're not going to have a discussion about the importance of disease modification in her, because she's just going to go home and take her herbs anyway. This was an actual case. What are the problems here? What are the issues creating the barrier here? It's the assumption, right, that she is not going to be amenable to this, that all she's married to is the idea that she can take herbs, a particular tea, and she'll be good. And she's not going to want to listen to me anyway, so why waste my time? What's the observation here? The observation here is that healthcare providers make assumptions about their patient's diagnosis or approach to their health based upon their own race and ethnicity. It affects the diagnoses we occur. If I say, well, she's Mexican, she just hurts a lot, so any pain is going to be over the top for her. Well, she's of East Asian descent, she's Chinese, she just has herbs and tea, and it's not going to matter what I say, because ultimately she'll take my prednisone for 5 days and she'll take her tea, and that'll be what she'll listen to. It affects the explanations of the diagnoses we give. The individual physician was no longer going to have a conversation, because what was the point? It affects the management options we offer. So one of the things that we do over at Valleywise, and I know that each and every one of you hopefully do as well, is we try to understand the differences in the approach based upon their own patients' traditions, value systems, and then we try to incorporate that into the visit or the plan. I always try to get an understanding of why is it that you decided to take this or this or this. Why is it that you are feeling this pain in this particular area? What can we do to incorporate what it is that you're doing for your own self to take care of your own body based on your value systems? And how can we incorporate that into a plan that will also help prevent further progression of your condition or your disease? A 62-year-old Spanish only speaking patient presents in follow-up for her rheumatoid arthritis. It's been very well controlled. She always sees me. We use our interpreters. Valleywise has an excellent interpretation service, live interpreters, though we do also have a phone service that we use pretty much on every other patient. She has never had a problem with me with communication, but she starts by asking me if I can write her pain medication. She was asked by her pain physician to only return to their clinic if she brought her own interpreter, as the staff there was not able to help and they didn't have any interpretation services. She was unable to go back. She's here telling me this because she had no one else that she could call to assist. Her son had to work at the time she had clinic appointments. What's the problem here? What is the issue creating the barrier to her getting adequate care? Well, she walks into an office where she's asking for optimal care for her pain. She's already controlled by her rheumatoid arthritis. This is separate. She has lumbar spinal stenosis. She needs the care of the pain specialist. Unfortunately, the barrier is the language. And it could be easily managed if there was just somebody else to help interpret. She didn't have that. A Spanish-speaking patient leaves 3 messages for the provider on the patient portal, and the phone never receives messages back. Well, the provider decided not to address the call. This was something that came across my desk by a physician because, well, I didn't understand what she was asking. It was in Spanish. I figured I would just see her in the office and we'd figure it out. Look, the barrier is the language barrier. But when you have interpretation services, you have individuals that can translate out over into English so that the provider, who's non-Spanish speaking, can understand and get the conversation going and get back to the patient. It's very basic. And frankly, when I was putting this, example down, I thought, well, how often does this really happen? It happens a lot. The observation here that language barriers limit delivery of healthcare. The physician may explain less detail because of the language barrier. The patient's not going to understand what I'm explaining anyway. I might just kind of break it down, but I don't need to get into all the details. Well, patients are left feeling that they would get better treatment if they spoke English. That's very upsetting to me to think that a patient could leave thinking, wow, I guess I understood, but maybe they would have treated me better. I have had patients who have actually said to me, Dr. Chhaya, I'm going to try to speak in English. And then I immediately get the interpreter on the phone because it's not okay for them to understand their to understand their disease if they don't fully understand what I am saying. And my medical Spanish is less than ideal. So physicians may also feel threatened by the constraints of time. I'm not saying we have an hour per patient. Boy, did I wish we did, but we don't. So it's understandable that when we have a Spanish-speaking individual, now you've doubled the time, right? I speak, they translate, the patient speaks, they translate, then I go back and forth. Physicians may also feel the limitations of their own inability to speak the language. So I changed this. As you can tell, I put in MIHS. It's kind of still wrote in my head, but Maricopa, Valleywise, we've had interpretation services since I started there 12 years ago. This is not a new thing at all. I understand it's oftentimes not subsidized. Oftentimes it's not reimbursed for private practices. It's quite pricey, but I think at the end of the day, it's very difficult to expect a patient to bring in their own interpreter. And from a legal standpoint, they have to be an adult. They have to be volunteering to do it. So we'll use them, but you can't have a 16-year-old child interpreting for their mother. 30-year-old African-American female presents for a first visit with joint pain. Her primary care provider sends her to rheumatology because she needs pain control and she's not compliant. Now, why is she not compliant or considered compliant? Well, she's had years of pain. She's had pain all over for years. It's made it difficult for her to hold a job consistently. She's asking for some help with her pain, but she also says, Doc, I also have this disability paperwork that you could possibly fill out. I don't think I can work. The barrier here is maybe not as clear cut for some, but in fact, it very well could be that the PCP thought, you know what, I'm not going to do this. She's asking for pain meds and disability paperwork because she doesn't want to work. There's that understanding, that thought that if you hand me a piece of paper for disability at the ripe young age of 30, that's laziness, or that's trying to get kind of the handout. And again, it hurts me to say all this, but it's true, and we've heard people say it. The observation is that perceptions of socioeconomic status often play a role in the equity of delivery of healthcare. Patients will often feel that they are perceived as coming from a lower socioeconomic class. If physicians perceive that they will receive less than optimal care. It's not a good thing for us to think about, is it? Physicians perceive such patients as having ulterior motives, such as, I want to be disabled. They're not Netflixing. they're a lot of these patients are requiring disability paperwork filled out for reasons that maybe the physician isn't aware of at initial glance. Patients perceive physicians as identifying Blacks and Hispanics as poor, uneducated, and on one survey study that was published by the Institute of Health coming of low breed. I'm just going to leave that there for a second. I mean, in 2022, this is how we're having conversations about what patients' perceptions are of what we as physicians and healthcare providers must be thinking. The patient wouldn't be able to afford a certain intervention, so why should I offer it anyway? That's a dangerous one, right? Because if you think the patient needs a CT scan to see if they have ILD, you better order the CT scan, or at least have a discussion with them about why we're going to have some limitations here. And also, they can't work, they're financially limited. The money goes towards food rather than their meds. I can't tell you how many times we've seen this trend happening. So what we do, and again, I think it's important for us to note that a lot of private practices, unfortunately, will not accept access. And that's just, at least in subspecialties, I can speak to this. And it's really kind of challenging. So unfortunately, a lot of times the patient has to come to an institution that will, or the patient just can't be seen. And we're too far, for example. Patients will often feel that they won't receive certain studies or workups or referrals because of their socioeconomic status. So we use full disclosure, right? I'll tell the patient, this is what I want to order. This is what's going to be more costly. The decision is yours. I give them the onus, right? You can decide what is cost prohibitive. You can decide what you're going to be able to pay for. We have financial services that will walk them through that and really look through what their subsidized plan or whatnot will be able to do. Depending on the hospital system, actually certain schedules actually have predetermined slots allocated for access patients, so at least they can get seen too. That's important. We had gone to open access schedules. We stopped for COVID, we've opened them back up. And that simply means that doesn't matter what your insurance payer source is or lack thereof, you call within 5 days. We're not urgent care, but we can certainly get our rheumatology established patients in, even if they are not able to have insurance. I won't say not able to pay, because there is something that comes up front, but we do what we can and leave the onus to put the onus on them. A physician has a list of patients that are on the schedule. Patients are on time. They are roomed appropriately. There's one patient who is Spanish speaking only and will require interpretation services, scheduled for the 9 a.m. slot. The physician tells his staff to move that patient out of her 9 a.m. slot, just schedule her at noon, because I don't have time to wait for an interpreter. So once in the exam room at noon, because the patient did stick around, because the patient only took that one day off, there's minimal time to exam. There's minimal discussion for, by the way, all of the other factors we just talked about, where where interpretation was needed, but the physician sort of felt X, Y, and Z. Let's just get the visit done. What is the problem? What is the issue creating the barrier? Well, yeah, it is the language discrepancy, the fact that he didn't get an interpreter right away, but it's something a little bit more than that. In the observational studies, the observation made was that ethnic minorities, these were survey-based. So patients were actually given these surveys, and they stated that they felt they got less respect, direct eye contact, less time was spent at each visit, less amount of times that the staff would assist patients, and longer wait times for return calls because of their ethnicity, because directly correlating with their language barrier, and also some felt very much that their ethnic background. So diversity of staff is incredibly important, and you'll see hospital systems really emphasizing this, bringing in diversity so patients can feel like they can trust everybody from the moment they walk in the door all the way till the moment they leave, and everybody they interact with. Bilingual staff, very, very important. Standardized patient satisfaction surveys keeps us on our toes, keeps us really trying to identify what it is that we need to change so we can give the patient the optimal experience. And by the way, it's not just them, right? Let's be selfish. This helps us too. It helps us in terms of compliance. It helps us feel more satisfied. Our patients get what we have trained all this time to be able to provide. And it really allows for more reception of education of providers too. Our providers want to learn this. We want to do better. A 45-year-old Middle Eastern female was wearing a traditional burqa. She presents for presumed osteoarthritis. She's seen by one of the male physicians, takes a history, does an initial physical exam, now needs to examine her knee because she's in for that. He explains that he's going to, but she asked him not to examine her knees underneath the burqa. He abruptly ended the visit. He said, well, you're here for knee pain. I can't properly diagnose you. If you're not going to cooperate, we're going to go. And that was brought up. It was something that we had to address. What are the issues creating the barrier here? Well, I think this goes right into, the next case where we talk a little bit about the 56-year-old Hispanic female asking for advice on how to lose weight. And she has a lot of pain, exercise is difficult. She feels she can't lose weight. She's concerned that she can't drop the weight without activity. The provider walks in, says, eat healthy, exercise, discusses it, walks out, ends the appointment. In both cases, what we have observed is that physicians need to be more aware of the impact of the cultural differences in the delivery and overall experience of healthcare. Patient trust will improve if that individual only said, okay, I appreciate what you're saying. I'm the only physician here. Would it be all right if I had maybe an escort, somebody to come in and watch over, somebody to help out with the exam? One of my female staff can come in, or may I recommend X, Y, and Z? Right? Give them the sense that you too are understanding of their cultural value system. In the individual who is trying to lose weight, it is not enough to tell someone whose main staple of food will be tortillas, rice, high carbs, just stop eating it. That may be the only thing that they're able to afford. Maybe culturally, that's what they eat. To them, that means they're eating healthy. Have the conversation. Patient trust improves, compliance improves, physician effectiveness improves, and patients will often feel more comfortable if we're not of similar ethnic or racial backgrounds, at least we can show them that this is important to us to help them. So in conclusion, and I went through just a plethora of cases here, but I think each and every one of us can dig deep and say, I had that patient in my office. Inequality in healthcare results from the interaction of complex factors, past and current discrimination in healthcare. Genetics, because again, different ethnicities, different disease proclivities and propensities, but unequal educational opportunities are there. So patients' health literacy may be different. Income and healthcare access disparities, cultural beliefs, community systems. Measures must be implemented to address such differences, close the gap of those ethnic and racial disparities at both the societal, and that's something that we really do need to be working on, but we as physicians can represent that at the provider level. And that's what I've wanted to show you, is that it starts with medical education and we progress forward. And I hope that we've been, in this very quick hour, I hope you've been able to see that, at Valleywise, we make that a priority. It is something that we are really instituting from the educational system of the medical students and residents on up. But really, as an attending and as a provider, we educate our staff, we educate our patients, we educate ourselves. So with that, I'm going to leave that. I think I actually did come in on time, so I'm incredibly proud of myself. But I think with that, thank you so much for your attention. This is an ongoing discussion. So this is not a lecture. This is not even, I mean, it's a webinar by definition, but honestly, it's a conversation and I look forward to continuing it. So thank you.